Welcome back, everyone, to OpenLine, talking about breast cancer and breast cancer awareness. Happy to have with us Dawn Eaton, CEO of the Susan G. Komen of Central Tennessee, Dr. Ben Ho Park, Professor of Medicine, Oncology at Vanderbilt, and Namaste Anderson, a survivor. Good conversation. And I want to talk about the 4 stages of the disease. Namaste said she was stage 3. What are the stages, and kind of give us a brief overview, I guess, doctor.
Well, there's actually technically now 5 stages because there's a little bit of a misnomer that we use the term stage 0 breast cancer, and that's actually the earliest kind of signs that there could be a breast cancer. We usually call that ductal carcinoma in situ, and that's when you have cancer cells that are kind of sitting there, but they haven't really invaded, and that's really what defines cancer. So there's a lot of confusion with that nomenclature, but I tell patients, I think of it as what a polyp is to colon cancer. It's on its way to becoming a cancer, but it's not quite there yet. But the reason we call it stage 0 is because we actually treat it as if it were a breast cancer, just like you take out a polyp so it doesn't turn into a cancer or a colon cancer. We remove DCIS so it doesn't turn into a real invasive cancer. And then there's, as you were mentioning, stage 1 through 4. We really kind of have 2 large buckets, if you will, of stage 4, and that's metastatic. That means when the disease has spread outside the breast or the lymph nodes. So it could go in the liver, the lungs, or the bone. Those are the most common sites. And that's generally not thought to be curable. We can treat it, and nowadays we have a lot of medicines that we can treat it effectively. And believe it or not, there are some patients with stage 4 disease that are dying with their disease rather than from it. And so that's kind of what I tell patients the goal really is in stage 4, if I see them for the first time with having a recurrence or a brand new metastatic diagnosis. On the other hand, stage 1 through 3 are all potentially curable. And the reason we have 3 stages, it really depends in the old days anatomically how much tumor you really have. How big is it in the breast? Do you have involved lymph nodes? And you can imagine the bigger bulk of disease, the worse the prognosis. So again, it's still curable if you're stage 3, but less likely than if you're stage 1. That's, rewinding the clock back 20-some years ago or more. What we've now understood is that, in fact, those receptors that I was talking about at the very beginning of the hour, estrogen receptor, progesterone, HER2, the reason those have become important is because they define not only the biology of the disease, but we have really good therapies that attack those receptors. As an example, HER2 positive breast cancer used to be the worst type of breast cancer to have, and that was again 20-some years ago. Now with drugs that attack that receptor, it has become the best type of breast cancer to have.
Wow.
So it really shows you what research can do. It's a total 180. And that is something that now we as oncologists have incorporated into our staging system. So even though we still use the traditional anatomic staging, as we call it, we now have what we say pathologic prognostic staging. And so you can have certain anatomic criteria but be in a worse or better stage depending on the status of the receptors. It's really, again, come a long way compared to when I was first training in oncology 20+ years ago. And I think that that also speaks to the fact that we have, as I was mentioning, really good drugs for this, and we just keep pushing that envelope further and further, again, through research and through things like the walk that support the research.
How fast does it progress? I mean, you talk about a stage 0. How quickly would it go from a stage 0 to the worst, stage 4?
And that's another kind of not easy question to answer because everyone is so different. And we know that for certain subcategories, it can take a really long time. We know for other types, like the worst type of breast cancer now prognostically is called triple negative breast cancer, so those don't express any of the receptors. Those tend to be much faster growing, not all of them, but many of them do, and so those can really, again, go from 0 to 60 really, really quickly. And that's why doing routine screening, getting breast exams by a clinically trained, healthcare professional really has come a long way into detecting breast cancers earlier so that the chance of cure, because now they're stage 1 instead of stage 3, is much, much higher.
And go ahead, yeah.
Well, I was just going to say, we were having a conversation today, was lucky enough to go on a tour of the facility, the lab, and about the changes that have happened. I've seen so many. First off, in patient care and just the way it's given and treatments, but the research has been phenomenal. And so he keeps referring to HER2. That when I was diagnosed, they just began to test for HER2, and the drug that they give, Herceptin, was in clinical trials, so it wasn't even available. And it was either you had it or you didn't. And now they look at it differently. There's like a scale involved. It's completely transformed how the treatment is given and the type of care that women get. So I'm really hopeful. And I'm really happy that my oncologist at the time said, here, we're going to do the best we can do today. We're going to worry about tomorrow. Because things are changing at such a rapid pace, we don't know what that's going to look like. And it was really sage advice. I really have taken that to heart. But it was so exciting to go into the lab and see all the progress that's being made and has been made over the past 20 years. It's really encouraging.
And you were saying that a lot of the money now that you're raising is going towards stage 4, right?
Right. So out of the 26 million, about 68 to 70% of that is going towards some kind of research around metastatic breast cancer. It is the one that is right now not curable, and it is the one that causes most of the deaths, the 41,000 deaths a year. So we really, our bold goal for Susan Komen is to reduce breast cancer deaths by 50% in the U.S. by the year 2026. So that is the reason we're spending so much money in that particular area.
And when you talk about, doctor, it varies, I guess, how quickly it can come on and advance. I think there's been some confusion about how often you should get tested. What do you recommend?
Yeah, that confusion and controversy, depending on who you read and who you believe. I think most of us in this business do feel like if you are an average risk woman, so you don't have a strong family history, etc., getting a baseline sometime in the early 40s makes sense. And then most different guidelines and medical professional societies and groups are in agreement that at age 50 it should be yearly mammogram. The 40 to 50 year span is a very controversial and difficult, many times because the breast density in a premenopausal woman's body is really difficult, and you can't see a lot with standard mammography. So there's a lot of research that's been done and refining that, so-called digital mammography, breast MRI, etc. The problem with those, they do increase our ability to pick up breast cancer, but they also increase our ability to pick up what we call false positives. So things that we find, we have to do the next steps, biopsy, and they end up being nothing. So there's always a price to pay for increased sensitivity, as the lack of specificity is what we say. And we're trying to get better at that, because obviously we'd like a really sensitive and specific screening test.
So after 50 every year?
Yeah.
And what?
Well, and I was just going to say, Komen encourages at the age of 25 to have a clinical breast exam, by a doctor or a professional, so that you know your body. A woman needs to know her body so that she can know what's normal for her and what's abnormal, so that they can detect any kind of changes, particularly between 25 and 40 before they have that first baseline.
Again, I think Namaste is an example of this. No one at 28, especially 20 years ago, is going to be thinking about, hey, do I have breast cancer? Should I be doing a self-breast exam? Should I get a mammogram?
Right.
And that's something, again, where doing something a little bit more proactive could go a long way.
Do you see tragic stories where, I guess, women haven't gotten tested, even though there's all this, it's recommended over and over, but do you see that where women aren't getting tested, and then it's something that maybe there could have been a different outcome?
Yeah. We see it all the time. Some of it is due to lack of awareness. It used to be called Breast Cancer Awareness Month, but I think we're changing some of that lingo. But some of it is just lack of awareness. A lot of it, and again, this goes back to the walk and the monies needed, is because of inappropriate or inaccessible healthcare. We just don't have the means to give everyone free mammography, and this is why it's so vitally important for organizations like Komen and the local affiliates to raise that money and then put it back in the community, so we can actually offer women who don't otherwise have the financial means or resources to get screening on a regular basis. It really literally saves lives, and I think that's, again, a huge important part of the mission.
We talk on this show a lot about the lack of health care and problems accessing health care. And so how are you helping make that happen for women that I guess they might not go and get tested because it's going to cost too much money, or they just don't feel like they have the time? There's a whole group of people out there who may be in that boat.
There are. Well, here's a great example. Another one of the programs that we fund, St. Thomas has a mobile mammography unit. and they go out beyond just even the borders of Davidson County. They go into a lot of the rural areas where there might be more of a lack of access or inability to get to a place that could actually do mammography, and they go out and provide those mammograms free of charge. And so that is one of the ways that we are reaching that particular population.
And you know that is saving lives.
We know it is, and I'll give you a perfect example. We have one of our ambassadors that actually found her cancer. She works for a large organization here. They took the mobile mammography unit to her place of work, and she actually detected her breast cancer there. And otherwise, she tells the story, she was a busy mom of several children, worked all the time, and she had just put it off getting her mammogram. And that actually saved her life. She caught it at a very early stage, and if I'm not mistaken, it was a stage 0.
Wow. So that's great.
Yeah.
And that's what's at stake here.
Yeah, and I think fear is a factor too. You know, I mean, I think like you
absolutely.
said before, that this is not a death sentence anymore.
Yeah.
And so there's no reason to avoid it because, like you said, the technology has improved so much. You diagnose it as stage 0. It could be potentially a very small procedure, and then you've got it, right?
Yeah.
The more you delay, it just the worse that it gets. And I think people are just really scared. They think, I don't want the diagnosis if it is something. And so I've known women that have avoided going even when they felt something because they're like, I don't want to know.
Yeah.
Wow.
But there is power in knowledge, and you can be empowered to make choices. And the earlier you detect it, the better the statistics are for your survival rate.
Yep.
And so
Absolutely.
10 years ago, doctor, how might you have treated some forms of breast cancer, and how has it changed today? I guess make us feel good about that.
Well, so
You can.
So
Yeah.
I mean, 10 years ago, we started having a little bit of an inkling of a test that we call Oncotype. This is a test for early stage curable breast cancer, but there's this subtype of patients who have estrogen receptor positive but HER2 negative disease that if we treated every patient in the early stage with chemotherapy, we're exposing them to the risk of chemotherapy, but only helping about that much, a really small minority. So what this test does, it actually allows us to take the woman's tumor, send it off. We do what's called a gene expression analysis. We don't have to go into the weeds about what that is, but it gives us a score and tells us what is the likelihood that this patient's breast cancer is going to be benefited from giving additional chemotherapy. And that, to really validate that clinically, takes a decade or more. So a study, in the meantime we were using it, but there was this black box of everyone who has this intermediate risk. We didn't know what to do, and that's what this trial set out through research to find the answer. Those were just reported out a couple of years ago, and it turns out, and many of us suspected this as we were treating patients along the way, that for postmenopausal women, the vast majority who have this type of breast cancer, which is the most common subtype, do not need chemotherapy.
That's great.
And that is huge, considering, one, how many women we're not going to expose anymore to chemotherapy. You think about the global picture of saving healthcare dollars, because chemotherapy is not cheap. But then also just the relief that I think many patients are going to face, that they don't have to get chemotherapy. I have some patients right now who they swore they were going to get chemotherapy, and we ordered this test, and lo and behold, they're not getting chemotherapy. So it's really been a big sea change in our business.
Huge sea change, and that's great. That's great news and shows progress. All right, so I want to take a break. If you want to call in, there's the number, 615-737+. Maybe you have a story of your own, you have a question. This is a great opportunity to ask. We're going to talk more about the walk that's coming up. We'll take a break, be back right after this.